Today I am very excited to be here, excited to see so much support for mental health in our community, in our beautiful city of Los Angeles. My passion for mental health drove my career to become a mental health practitioner. And I am a nurse practitioner that specializes in psychiatry. And it's so incredible to see how many changes we're making to advocate for mental health. And in our beautiful city, we have the highest rate of the unhoused population in America. We have over 71,000 unhoused individuals here. And 63% of those individuals suffer from mental illness. So today I want to offer my clinical perspective on long-acting injectables in the treatment of unhoused individuals. And we will discuss the roles of long-acting injectables, barriers, and addressing barriers to promote access. So what are long-acting injectables? We call them LAIs for short. I don't know what happened to my slide there, but they are injections that are antipsychotics, and instead of traditionally taking the oral medication, the patient will get an injection and it will release throughout a certain period of time. Usually it takes about 4 weeks for every injection, although there are formulations now that are available for 2-month and 6-month intervals, such as Invega. We have Haldol, we have paliperidone, which is Invega, we have Abilify, and newer formulations such as Perseris, which is subcutaneous. So LAIs provide a lot of benefits for our patients. They improve adherence, they reduce relapse rates, and enhance the quality of life. And it's important to note that there is a reduced frequency of administering medication, which is why patients typically stay more compliant with this type of medication. And our goal in psychiatry is successful symptom treatment, which LAIs provide a more stable level of the drug in the blood versus taking oral antipsychotics. So some statistics that tell us more about the benefits. As many as 2/3 of patients that are diagnosed with schizophrenia and on antipsychotic medication are not adherent to oral treatment. And this results in a lot of rehospitalizations, a lot of relapse, a lot of just the revolving door that we deal with all the time. So LAIs can reduce the readmission rate by 29% compared to oral medications, and LAIs also can reduce readmission rate by 58% in patients with repeated admissions. LAIs provide an overall 85% reduction in relapse risk, which is what we frequently see in our practice. So of course they offer a lot of benefits, but with benefits we always have barriers. Let's discuss them. Barrier number 1 is a lack of accessibility for facilities administering LAIs. So with the unhoused population, their resources are limited naturally, and it's difficult when we have patients in the hospital and we cannot track down their records of their history. We solely rely on their own reports, which sometimes are accurate, sometimes they're not. And when they are discharged from the hospital, it's really an issue trying to get them the adequate follow-up care. Barrier number 2 are financial barriers, high cost, limited insurance coverage. Now, dealing with unhoused population specifically, we deal with a lot of no insurance patients. These patients don't have the means to have health insurance, and so this could be a barrier. And barrier number 3, we talked a lot about stigma today. There's stigma everywhere. It will always be there. So it's our job to educate and get over those beliefs. So promoting access, so how can we promote access? We can expand outreach programs to reach unhoused individuals, such as mobile services or more. I know pharmacies now are actually giving these injectables, but there is a gap between the provider and trying to connect with a site that would be able to provide these types of injectables for people that don't have a living situation. So that needs to be addressed. Also, increasing funding for mental health and substance abuse, that's always prevalent. Combating stigma surrounding through education and advocacy, this is important not only to us providers and educating ourselves to be able to use these long-acting injectables to promote compliance, but also for our patients. Our patients need to be educated thoroughly on their disease process and their risks and benefits of treatment, because oftentimes they have a misconception and that can hinder their ability to even want to be treated. And finally, implementing policies to promote long-acting injectables. This includes insurance and training. Insurance policies that could be more, have a easier access to those with that are unhoused. Sometimes, like we said before, these patients don't even have insurance. So there are policies in place that are helping and getting better, but the training is also necessary for providers so that we are adequately trained. And instead of maybe using long-acting injectables as a solution to non-compliance, maybe we can use it as a start of treatment and offer it at start of treatment so that we won't experience non-compliance issues later on. And as we conclude our discussion, I thank you for listening to me. Thank you for listening to my clinical perspective, and hopefully we can transform and break the cycle of relapse and instability in this community. Hopefully we can get together and make a change for the patients that we serve. And in the famous words of Mahatma Gandhi, the best way to find yourself is to lose yourself in the service of others. Thank you.